Live.
Hello, hello. Hi, everyone. Welcome to Black Maternal Health and Cardiovascular Health. If you can hear us, can you just drop in the chat where you are tuning in from? We just want to make sure that our audio is working well. So I'm looking in the chat. Again, if you can hear us, please drop in the chat where you're tuning in from. Okay, great. We're tuning from NYC. Okay, great. We have some folks joining us from New York. Okay, and Jeanette from New York. Okay, all right, so everyone can hear us. So good evening, my name is Crystal and I am head of community here at Black Health Connect. And I'm also a registered nurse. So I'm very happy to be here with you all tonight. This event essentially was created in honor of Women's History Month, right? So with increased media attention on Black women's maternal mortality rate, this discussion will explore and discuss the impacts of heart diseases on Black women's maternity mortality rates. Black women are 3 times more likely to experience pregnancy death in comparison to their white counterparts. According to the American Heart Association, 58% of Black women are unaware of heart disease signs and symptoms. So in this panel discussion tonight, we will talk with Dr. Paul and Dr. Beauzile, who will answer questions that will highlight how heart disease impacts maternal mortality rate in the Black community. So I first want to start off by introducing our speakers for tonight. So I have Dr. Paul, who is tuning in here, and she is an assistant professor of clinical medicine in Weill Cornell Medicine's Division of Cardiology. She practices general cardiology, critical care cardiology, and echocardiography. Her research interests include women's cardiovascular health, cardio-obstetrics, and health equity. She is a member of Weill Cornell's Women's Heart Program and the Cornell Center for Health Equity. So that's Dr. Paul. She's going to be our cardiologist for tonight. And then Dr. Beauzile, if you could just give us a wave.
Hello.
So Dr. Beauzile is an established, highly skilled, and board-certified OB serving the women of Southwest Virginia. She is originally from Washington, D.C. She serves as a clinical assistant professor for the Department of Obstetrics and Gynecology for both Edward Via College of Osteopathic Medicine and Virginia Tech School of Medicine. In addition to her academic, clinical, and surgical practice, Dr. Beauzile is well regarded in her specialty. In 2018, she was named a Washingtonian top doctor, chosen by physicians working in the DC area, Maryland, and Virginia metro area. She is currently the chair of the Department of Obstetrics and Gynecology at Carline New River Valley Medical Center, a nonprofit medical center providing care for patients in Southern Virginia. So as we can see, our doctors tonight are very accomplished and knowledgeable in their field. So I'm so happy to have you two here tonight. So first, what I want to do is just introduce Black Health Connect and Health in Her Hue. So essentially, Black Health Connect is a digital and physical hub for Black health professionals to build a network and gain access to different career opportunities. And Health in Her Hue is a digital platform connecting Black women and women of color to culturally competent healthcare providers, health content, and community. So we wanted to do a partnership for this event so that we could just bring awareness and discuss concerns when it comes to cardiovascular health and Black women and pregnancy. So general housekeeping, if you have any questions, please use your Ask a Question button, which you can find at the bottom of the screen. You can click that button, type in your question, and then when we have about 20 to 30 minutes left in the discussion, I'm going to address all questions there that weren't answered already organically. So please feel free to ask questions, and we will get to them towards the end of the discussion. So we're going to begin first asking Dr. Paula, what is... and symptoms?
Sorry, you were kind of coming in and out. You asked, say the question again.
Oh, I'm sorry. Okay, so the first question is, what is heart disease? And can you tell us some information on signs and symptoms of heart disease?
Sure. So heart disease is a very broad term. And so I think the best way to think about it is the sort of heart disease that you're born with and heart disease that you may develop later on in life. Does everyone hear like an echo?
Yeah, I do hear a little bit of an echo.
I'm not sure why.
So
okay, let me close this mic and then.
Yeah, maybe we could close the mic and then join again. Sorry for some technical difficulties. We have Ashley working on our tech.
Okay, let me see.
So Ash, if you could just let us know with the echo.
Is that better? Is the echo gone?
That's better.
Okay, thanks. All right. So what is heart disease? So heart disease basically describes diseases that affect the heart and also the vessels that bring blood to and from the heart, so the arteries and the veins. And so overall, we can call it cardiovascular disease. And like I was saying before, with heart disease, we think about heart disease that you're born with, which is called congenital heart disease, which is kind of a whole other separate entity, and then acquired heart disease. And what we've been noticing more and more, especially when it comes to like maternal health, is that people who have a history of acquired heart disease, and I'll talk about more what that is, that they're at higher risk of having poorer outcomes during pregnancy and in the postpartum period and later on in life. So what is acquired heart disease? So acquired heart disease, we're talking about things like coronary artery disease, which basically means like plaque buildup in the arteries, people who are at risk for having a heart attack. We're talking about people who have heart failure, so like a heart pumping function that is low. We're also talking about people who have valve disorders. The heart has 4 heart valves that help to control flow throughout the heart so that it goes the correct way. And it's a myriad of things, like so many different things fall under heart disease. Ways that you would know that you have heart disease is really, seeing your doctor as an adult woman yearly for just basic checkup and making sure that what's important are your numbers. And so signs that you may possibly have a heart disease could include, having high blood pressure, having high cholesterol, having a history of diabetes, or what we call pre-diabetes, like people with increased sugar levels. So those are top 3 things. And also sometimes like people who have like excess weight as well are at increased risk for having heart disease. And so depending on the type of heart disease, because like since it's such a big umbrella term, there are many different symptoms that could present that could possibly be heart disease. But the main ones to really be concerned about and that you should definitely talk to your doctor about is if you start to experience like chest pain, if you notice that you have shortness of breath, especially like when you're like doing exercise or just walking, climbing upstairs, if you notice that you have like swelling in your legs, things like that. Those are like also like heart palpitations, like heart beating very quickly. Those are some major like symptoms that could clue you in that it may be heart related. Like not all those symptoms are just from heart disease, but it may be. And so that you should have that kind of in the back of your mind, like, maybe I should get checked out about this.
Yeah, thank you for touching on those risks. And just a follow-up question. So what about family history? Like what role does that play when it comes to like, should we be getting more checkups or on the lookout for certain types of symptoms if we know that like our mother or father has a history of heart disease?
So that's a great question. So definitely family history is an established like risk factor for development of heart disease. And when we talk about family history, we're talking about a first degree relative. So your mom, your dad, your brother, your sister, who has had some sort of heart event. And so usually when we talk about family history of heart disease, we're talking about heart attack. And it's important to know, do you have a male relative who had a heart attack at the age of 55 or younger, or a female relative with a heart attack at the age of 65 or younger? Because that gives us clues that, that it may be that you have like a genetic predisposition to having a heart attack earlier in life. Other parts of family history that it's important for your doctor to know is, has there been somebody in your family who just died suddenly for a reason that, it's unclear, like a young person, did they die in their sleep? That can indicate certain sort of cardiac disorders. Do you have family members who died from like blood clots? That can create like a clotting disorder as well that can affect the heart. So I think it's very important, especially those of us who are people of color, Black people, that we need to talk to our family, because sometimes there's a lot of stigma in our home lives about like, family members being sick and not wanting to share. But it's important. And I always say this, like, what kind of rocked me one time is like, I remember I was walking in the hospital and I saw like, a friend of mine from like college. So like somebody like our age, you know what I mean? Like kind of like in mid 30s, late 30s. And he had like a hospital gown on, and I was like, wait, what happened? He was like, I had a heart attack. And I was like, really? And then he said, yeah. And then he goes, when I was talking to my mom and I mentioned that I had a heart attack, she's like, oh yeah, that happened to me too when I was 39. And he had no idea.
No idea until the event actually took place.
Until it happened.
Right.
Exactly.
And there could have been preventative measures.
Thank you.
Taken.
Right.
Yeah.
Exactly. So it's so important for us to know like what has happened with our elders and what's happened with our siblings, so that we can talk to our doctors and be like, this person had a heart attack, like I'm concerned, can you screen me, can we make sure that I like everything is updated and that I'm living my life the best way I can to prevent that from happening to me.
Yeah, and I love that you mentioned that, because I feel like that can empower us, to take control of our health, knowing our health history. So thank you for highlighting the importance of knowing our family history and actually having these hard conversations. So I want to bring Dr. Beauzile into this conversation and just ask you, what are the impacts of heart disease on pregnancy?
So actually, pregnancy affects all the organ systems, and one of the most important organ systems, obviously, is the cardiovascular system. And so in a patient who doesn't have any heart disease at all, they're still being affected by the pregnancy. So the pregnancy in itself stresses your heart and your circulatory system. You double your cardiac output or blood volume when you're pregnant, and that's in preparation for obviously the baby, the delivery, and to nourish this growing pregnancy. In addition, your heart is pumping out more blood, and your heart is working a lot harder when you're pregnant. So that's, again, in someone who has no history of heart disease, your heart is already kind of being stressed during pregnancy. In addition, during labor, there's a lot of fluid changes that occur while you're in labor. Specifically, when you're in the hospital too, you're getting IV fluids. There are a lot of fluid shifts. And then definitely during pushing, when you're actually pushing the baby out, there are a lot of fluid changes. So the effects of pregnancy on the cardiovascular system are significant, and they actually can last up to 12 weeks after you've had the baby. So again, that's a patient who has no heart disease. So when we're talking about some of the indications that Dr. Paul was talking about, patients who already have blood pressure issues, who have valvular issues, those patients are going to be at a higher risk for complications because they have a condition that's kind of weak in their cardiovascular system, weak in their heart, and adding a pregnancy onto it definitely puts them in that high risk category and stresses the heart even more.
Yeah, thank you, Dr. Beauzile. And I'm glad you touched on the postpartum phase, right? Because sometimes we focus so much on, when you're pregnant, how you should be eating, what you should be looking out for. But there are also signs that we have to look for postpartum. So I'm glad that you addressed that. I actually wanted to kind of touch on like blood pressure medication, preeclampsia, and just I want to hear more about how that process is and whether or not the blood pressure medication affects the baby while person is pregnant. And if you could just walk us through that process for somebody who hasn't had a diagnosis prior to pregnancy of hypertension. And Dr. Tracy.
So preeclampsia is one of the oldest diseases. Oh, sorry, go ahead.
Yeah, no, it's breaking up a bit. No, go ahead, Dr. Beauzile.
Okay. You're great. So preeclampsia is one of the oldest diseases that affects pregnant women. It's specifically Okay. Can you hear me?
We can hear you. Yeah, it was just breaking up a little bit. Yeah, we can hear you.
We can hear you. Yeah.
Can you hear me? Are you able to hear what I'm saying?
Yes, we can, and we can see you. Yeah.
Yes.
Yes, we can hear you.
Okay, I think Dr. Beauzile may.
So, like I was saying, preeclampsia is one of the. Okay. So it's one of the oldest diseases that affects pregnant women. Okay. It's characterized by changes in the blood pressure.
Okay, I think we are having some technical difficulties with Dr. Beauzile. Can you hear her, Dr. Paul?
It's coming in and out.
It's coming in and out, right? Okay, so I'm going to talk to our tech team. Yeah, it's waiting. So in the meantime, Dr. Paul, if you could just kind of, lean in with that question, that would be great to provide us some insight, because I know that's your realm as well.
Dr. Beauzile was saying, like, preeclampsia, it's a very old diagnosis, meaning it's been around for a long time, and doctors have recognized this. It's even in pop culture, because in Downton Abbey, if anybody watched that show, one of the main characters, she died from having going on to developing eclampsia. So it's something that has been well known and well documented for decades. And so basically what you see is that after 20 weeks, women start to have higher blood pressure. Also, this is the reason why when you reach a certain part in your pregnancy, why you have to see your OB more frequently and have urine tests, because they're looking to see if you have protein. Because basically what happens is there a change in the membrane,
right?
So vasculature in the kidneys, and you start to leak protein from your blood into your urine. Okay. And so this change in it's a vascular change that, while we know that it exists, the direct science behind it, there's still some hypotheses about why do certain women have it, why does it develop, and what can we do to prevent it. So things that we've learned recently with preeclampsia is we've identified certain groups at higher risk, and so they're usually women who are in this group called the advanced maternal age, so 35.
AMA, yes, 35 and up. I was a labor and delivery nurse, so I know all of these terms. And I remember when I saw AMA for the first time as a diagnosis, and I'm like, what? AMA? What is this? And they were like, advanced maternal age. It does make you more high risk. So I'm glad you're bringing that up.
Advanced maternal AMA, or sometimes they'll call it geriatric pregnancy.
Yes.
It's very rude. I think the terms are rude.
I know.
AMA. So that, and then also we're noticing that women of African ancestry also carry a higher risk. Women who have history of excess weight, women who have prior history of higher blood pressure, things like that, that they tend to have a higher likelihood of developing preeclampsia. And people who had preeclampsia with previous pregnancies also have a risk. And so some ways that we've discovered to mitigate that risk is actually taking baby aspirin during pregnancy to help to prevent these changes.
Which is a blood thinner. So
Yeah, so it's a blood thinner. So it's an antiplatelet.
mhm.
Just a little bit of baby aspirin, and that's been shown to decrease occurrence of preeclampsia. So really, like a main like warning sign in terms of preeclampsia that we all need to be aware of, like if you're starting to have like headaches, like you really shouldn't be having headaches, like severe headaches towards like the end of pregnancy. We're talking about like so like second trimester into like third trimester. So that's
Mhm.
really a big warning sign. If you notice that like the swelling that you're having in your legs, like if it's a ton of swelling, that's something you need to get checked. If you notice that like if you're very short of breath, like during pregnancy, there is what we call like physiologic shortness of breath, which is
Mhm.
sometimes due to like the hormonal changes, but also sometimes due like towards the end of the pregnancy where the uterus kind of pushes up because it's filled with a baby on your diaphragm, so you can't breathe as well. But if you're noticing like extreme shortness of breath, like you can't like even get up to go to the bathroom, that's something you need to talk to your doctor about. And then in terms of like preeclampsia, sometimes it can have like severe features where you have like very high blood pressures. Also, sometimes it can affect like platelet counts and in some cases, like the more extreme cases, it can go on to where you actually have seizures and whatnot. So it's a very
Wow, yeah, like that's
complex,
a severe case.
yeah, and very serious condition. And
Yeah.
Dr. Bazil will talk about it when she comes back because that's what OBs deal with day in and day out. And really, what we've learned is that really the only real cure for this is actually to deliver the baby and have take
Mm.
it out. Another thing to note though is that some women even develop like preeclampsia, eclampsia like features even after they deliver. So even after
Right, in the
they
postpartum
deliver,
phase. Yeah.
exactly postpartum phase. And so, it's very important to be aware of like what your blood pressure is during that time. And even though, and from my understanding, at least from cardiology perspective, like our like cardiology societies, like we don't have any formal recommendations about like blood pressure management after delivery. But I tell my patients and I tell my friends, like, if you're pregnant, you need to buy a blood pressure cuff and you need to have a blood pressure cuff in your house.
Right.
And you should check your blood
Okay,
pressure.
we have Dr. Bozo back.
Sorry.
We'll talk more. Yeah.
No, that's okay. We're still discussing preeclampsia and hypertension during pregnancy. So Dr. Paul was just touching on that.
Okay.
So feel free to just tag in. So sorry to cut you off. You can continue, Dr. Paul.
No, I'm deferring to Dr. Bozo because this is her baby. Hers are preeclampsia.
Well, I don't know what you touched on. I'm sorry, my connection is kind of sketchy. But yeah, it's really common in pregnancy. It does tend to affect Black moms a lot more, but it does affect all women. It's very common. I see multiple patients weekly with preeclampsia that I'm managing. So it's really important for it to be diagnosed very quickly once you do have the symptoms and to be treated, because obviously if left untreated, there can be really serious ramifications like death of mom, death of baby, a hemorrhagic stroke, which means you bleed in the brain, neurological symptoms, kidney dysfunction. So it can get really bad very quickly.
Right. And Dr. Paul was just touching on ways that we could recognize high blood pressure, and she said that she recommends to her patients who are postpartum that they purchase a blood pressure machine so that they can measure their blood pressure on a consistent basis.
Yep. I do tell my patients during pregnancy, especially if they are at a high risk for having preeclampsia. So patients who have had a history of hypertension, patients who are obese, patients who have diabetes, even patients with autoimmune disorder, low vitamin D, all those patients are at risk for preeclampsia. So we do have patients check their blood pressures at home. I always tell them to make sure that you're checking your blood pressures routinely and not just when you're feeling bad, because if you're feeling bad, your blood pressure is going to be abnormal. If you're upset about something, if you don't feel very good, your blood pressure is going to be abnormal. So I tell patients, do it on a scheduled basis. So if you are going to check your blood pressures, check them at the same time every day. Make sure that you've had time to rest for 10 to 15 minutes before checking your blood pressures. Make sure you're sitting down, have your arms at the level of your heart, take some deep breaths, and then check your blood pressures versus, oh, I don't feel good, let me check my blood pressure. Obviously, it's going to be abnormal.
Right. And this kind of leads into my next question, which is how does stress affect one, blood pressure, two, development of heart disease during pregnancy and in the postpartum phase?
So the thing about blood pressures in pregnancy is that they actually go lower in pregnancy. So if your average blood pressure, let's say it's like, you know, in the one teens over 70s or 80s, in pregnancy, it's probably going to be lower, maybe low 100s over 60s. So when your blood pressures are higher in pregnancy, that by itself is a sign that something else could be going wrong, because typically your blood pressures are going to be lower in pregnancy. But at the same time, if you're stressed out, your blood pressures will be affected. If you haven't eaten all day, if you're dehydrated, if you're anxious, if you're worried, all those things can affect your blood pressures, but those changes should not be persistent. So yes, if you're having, you know, some anxiety about the pregnancy, you're really upset about something, yes, your blood pressure may be a little bit higher, but it shouldn't be sustained. It shouldn't be persistent. But even then, we still worry because your blood pressure should be lower when you're pregnant.
During pregnancy. Okay. Yeah. Thank you. Just you know, just for the audience to know, I know we're all health professionals, but what would be the standard number for like a normal blood pressure, that range? And then what would be the range for a blood pressure during pregnancy?
So this is actually an interesting question because the kind of targets for blood pressures keep changing. So, you know,
okay,
we typically used to think like 120s over 80,
120 over 80, right,
was normal. And, you know, in the most recent literature, they're saying that that is like considered early stage, like pre-hypertension.
Wow,
and so now,
I wasn't aware of that.
And Dr. Paul can talk to that more. So now it's more like, you know, 110s over 170s, 160s is actually more of a target blood pressure versus like somebody who's in the 130s over 80s is going to be kind of considered pre-hypertension. And then definitely you're in the hypertension range when that top number is 140 or greater and the bottom number is 90 or greater. Now, if that top number gets to 160 or greater and the bottom number is 110 or greater, that is called severe hypertension, and that's stroke range. So
I feel like this is making me want to bring out my blood pressure. I'm a nurse, so I have my bag and I go to my patients' homes. I have the blood pressure machine. This is making me want to just measure my blood pressure just to make sure with these changing targets.
Don't check it now. It'll be high just because you're active, you're doing stuff.
Right. I have to see when I'm calm and zen. Yes, you are right. But yeah, Dr. Paul, so what is your input with the changing blood pressure ranges and recognizing which stage
in terms of like blood pressure range for like pregnant women and women with postpartum, it's a little bit different, just like how Dr. Beauzile like outlined and like what's considered severe. For us in like cardiology, in terms of like what's considered high blood pressure, and now the guidelines are 130 over 80, excuse me. So blood pressure 130 over 80 will give you a diagnosis of hypertension. But we don't talk about like needing medication to treat until you're like over 140 over 90 on two separate occasions. And like Dr. Beauzile mentioned, before we always be like, oh, it's 120 over 80, you're fine. But like research has shown that ideally you should be less than 120 over 80. But if you are in the 120 over 80 range, it's kind of like a warning sign, like, okay, you know, you need to watch what you're eating.
Right. You need some lifestyle changes.
Exactly. Like modify your salt intake, maybe increase the amount of exercise that you're doing. But it's a warning sign. And a lot of this, like it hasn't really changed per se how we treat hypertension really, like in terms of medication. What it has done is just expanded the definition of who is hypertensive. And part of it is to kind of get into people's mind, like when they're in the 130s over 80s, like this is not normal. You need to change this, because if it goes up higher, then you'll be on blood pressure meds.
Yeah, no, I'm glad you touched on that and the importance of lifestyle changes. I wanted to know what eating lifestyle changes do you recommend for someone who's looking to get pregnant?
Sure. So I think there's now a bigger push in terms of those of us, not only just in cardiology, but like internal medicine, family medicine who like see young women to talk about like preconception counseling. And part of preconception counseling is examining the person's lifestyle. So in terms of like lifestyle changes you can make or continue to have, because I'm sure a lot of us are doing it already, to ensure that you know that one, that we'll have healthy pregnancies, and two, that we won't go on to develop like heart disease, is one, you really want to try to, as much as you can, have like as much of a plant-based diet as possible. So when you talk about plant-based diet, we're talking about like very colorful, like green leafy vegetables. Like when you think of your plate as a circle, half of your plate, half of that circle should be vegetables, right? And
Right.
it should be like vegetables prepared like in a healthy way, you know, either like raw, lightly sauteed, nothing like heavy batter or anything like that,
Yeah.
no heavy salt. And then you want like protein, you know, 5 ounces of protein, of lean protein, you know, so like lean turkey, chicken,
I saw you were making a
fish.
symbol. Can you make the symbol
Oh
of
no,
the
that's
5?
me making my little thing. It's just it's not really.
Right. Because that's like literally, that's kind of close to it. The
Like
5 ounces. Yeah.
it's like a deck of cards, you know.
Right.
And then like the other quarter, you can have like complex like starches, you know, like sweet potato, like quinoa, bulgur. And I mean, people are like, oh, you know, that's not really that tasty. But ways you can make the food tasty is like, instead of using a lot of salt, you could use like some lemon to kind of give you that like kind of like saltish sort of
Yeah, like
flavor.
some flavor. Yeah.
Exactly. And like using
Garlic.
your
Use
herbs.
garlic as well.
Exactly. A lot of garlic as well, onion. And it's really to, one, to decrease amount of salt. Like we recommend that you should be about like less than 2 grams of salt a day, which is very hard to do. Okay. So, you know, try to target 2.5 grams or less. Um, and less like fats. And when you do, and I mean, there are healthy fats like avocado, certain olive oils, things like that. But like, you want to kind of diminish like trans fats and like those sorts of things, and unsaturated fats. So those are the main things I would focus on, at least diet wise. And then we're talking about exercise. And so we recommend that at minimum people should be doing 150 minutes of moderate exercise per week. And so that really is just like walking, like 30
Right.
minutes of walking a day. And when we say moderate, it's like you're just like a moderate, like a brisk walk, like you're walking down the street.
Brisk walk. Yeah, even going
Yeah.
outside. Because even now, I mean, a lot of us are working from home. Not everyone, but if you're working from home, it's harder to get that exercise that you would have gotten before naturally. So we really have to be intentional about making sure we get that brisk walk in.
Yeah, and doing some sort of extra. Other things that you could do if you want to do vigorous exercise. So like, you know, I mean, I think everyone, I don't have one, but I know a lot of people have Peloton.
Peloton, yeah.
I don't have one. But like if you have Peloton, or you're doing like these very like vigorous activities, and actually like we'll say you could do 75 minutes a week, right? So it's like you do a class and a half and like you meet your target. But the thing to remember though, that is just like what basics that you should do if you want to maintain the current weight that you are. If you're thinking about that you want to lose some weight, then we actually recommend doing like 300 minutes of moderate exercise a week. So like doubling that, you know? But the main thing really is diet, and really trying to avoid like, you know, the processed foods, the red meats, all that stuff. And I mean, I'm not saying like we all eat it, like I eat it too, but like to try to do it in moderation, right?
Right.
That's the key thing, moderation.
Yeah, no, definitely. And I mean, even on top of these like dietary changes, I know that mental health can really impact our physical health. So I would like to know your thoughts from both of you. How do we, you know, balance our mental health and also our cardiovascular health?
So, you know, in pregnancy, there's definitely a lot of changes to the mental health, and definitely mental health just for all women who are pregnant tends to like get a little bit more challenging towards the end of pregnancy, like in the 3rd trimester and definitely postpartum. And then obviously, you know, anxiety and depression are so common these days. So I have a lot of patients who come into pregnancy with you know, anxiety and depression, and it only kind of sort of gets worse a little bit as the pregnancy goes on. And that's just the nature of, you know, this whole life change of bringing a new child into the world, having anxieties about the pregnancy and the health of the baby, having anxiety about what's going to happen during delivery. I mean, there's so many things that expecting moms are thinking about and are concerned about. I mean, financial, there's so many different things. So, you know, like Dr. Paul was saying, exercise, in addition to weight loss and just good cardiovascular health, it's really good for mental health, you know? So we do talk to our patients about like 30 minutes of kind of something that like a brisk walk or like a run a day, just to help clear your mind, practicing mindfulness, practicing meditation, things like that to help just make, you know, these day-to-day stressors that we have a little bit more palatable for us. Obviously, everybody has different degrees of anxiety and depression. Some people will need medication, some people won't. And, you know, counseling is also really helpful because although medication can help treat a lot of mood disorders, you have to be able to cope with the changes in your mood. And that's not really going to happen with just medication only. It's going to happen with behavioral therapy and learning skills to cope with anxiety and cope with moments of, you know, depression. So, I mean, this is a conversation that I have with my patients all the time about, number one, recognizing when you do have a mood disorder like anxiety or depression or panic disorder, anything like that. There's just so many different things. And also being okay with it, right? Because we have gone through such a rough year that I can't think of anybody whose mental health is like in tip-top shape right now. Okay.
Right. I know I've had to message my therapist, like we need to talk. Calendar. Yeah. So it's important.
You know, right. And imagine being pregnant, or imagine just having anything else happen to you just in the midst of this pandemic, having a family member be sick, having a loss, being out of work, worried about money. I mean, so I think that, you know, I'm just so glad that mental health is becoming more and more mainstream to talk about and not so stigmatized. But I mean, we still have a long way to go. And definitely mental health and pregnancy go hand in hand. So I am doing a lot of like psychiatry as an obstetrician.
No, I'm glad you touched on that. Mental health is so important right now, and especially for Black women, right? I'm glad that there's a lot of attention and awareness being brought to this topic because it definitely affects us on a high level. Dr. Paul, I just want to know your comments when it comes to stress that we have now, and even for women who have not had kids yet. How can that impact their chances of pregnancy and chances of heart disease?
So we do know that stress is definitely linked to heart disease, that people who have more like stressful situations, like who come from who are in like challenging situations from like lack of resources, like lack of like easy access to like healthy food, lack of like stable housing, those sorts of social determinants of health, that's like a huge that's a huge contributor to stress, and that can lead to like increased rates of like high blood pressure, you know, poor dietary choices that lead to like, you know, developing like high cholesterol, developing diabetes, and so on and so forth. So it's like, you know, like one domino is triggered and then there's just this chain effect. Other things we know is with stress is like, you know, even in the setting of stress, like a lot of us don't get enough sleep. And we've seen that, you know, people who have routinely like low amounts of sleep. So we're talking about people who are sleeping like 4, 5, 5.5 hours a night routinely, that they're higher risk of having high blood pressure. Because like your vasculature, basically your arteries are not given a chance to like rest overnight, because like you're still kind of like, you don't get like your 8 hours where your body can just like reset. So definitely stress in prior to pregnancy can increases one's risk of going on to developing like heart disease or risk factors for heart disease. And I think Dr. Beauzile can answer more about like how stress particularly affects one's chances of conceiving. But in general, like, you know, like if you're stressed out, you may not even want to be having sex to even try to conceive. So like,
that's very true. Yes.
So stress is a huge thing. And like Dr. Beauzile said, like, it's great that mental health is finally getting a point in our community where that stigma is being removed, you know? And it's important that we get that help, you know, that we talk to a therapist, that like we do the work that we need to do so we can continue like living not only just like a physically healthy life, but a mentally healthy life as
Right.
well.
Which leads us to a holistically well life,
Yeah.
right?
Mm-hmm.
Yeah.
Yeah. So as far to what you were saying about getting pregnant, definitely like what Dr. Paul is saying, stress plays a big factor with fertility, right? So just the very basics, if you're depressed or you're anxious, yes, you're not going to have sex, right? But also if you are self-medicating with alcohol or drugs or food, all those things can affect your fertility. Smoking can affect your ability to get pregnant. It can also cause you to get pregnant and have a miscarriage.
And what type I just want to clarify, what type of smoking? Like smoking what exactly?
So specifically tobacco products for certain can affect your ability, number one, to get pregnant. It can affect the ability of the sperm to be motile in men. And it can also increase your risk for miscarriage. Now, as far as marijuana is concerned, it doesn't particularly marijuana by itself affect fertility as far as I know, but if you're smoking it in a tobacco cigarette or you're smoking it in whatever kind of vehicle you want to use it, and there's other additives to it, that could potentially affect fertility. And as far as we know, in studies that have looked at children who've been exposed to marijuana early and students in high school, their cognitive abilities are significantly decreased when they've been exposed to marijuana early. So you can only imagine or kind of extrapolate what that would do to the cognitive ability of a fetus and a newborn, right? So of course, there's not going to be a lot of research on pregnant women and marijuana and how it affects their baby, unless they kind of volunteer for a registry, which a lot of women who are using marijuana won't do. But if you already know how it affects school-aged kids and children, then obviously those effects are going to transfer to the pregnancy. Additionally, obesity can affect fertility. There's so many different ways that it can affect fertility, but one of the things is that it can affect ovulation. So if you've gained a lot of weight and you've noticed that your periods have changed and become more abnormal, it could be that you're not ovulating. And if you're not ovulating regularly, this is going to be a problem for you when you try to get pregnant. And so if you kind of take this back to stress, right? A lot of us do stress eating. You gain the weight, you have changes in your menstrual cycle, and then it's harder for you to get pregnant.
Right. No, I love that we're talking about how our lifestyle choices can affect possible fertility, chance of heart disease, right? It's not always just genetic predisposition. So I'm glad we're talking about that. Thank you all. I really want to get to these questions that we have here. I'm gonna, again, if you have a question, please click on the ask a question button and just type it in and we will address it right now. We're coming into our question section of this discussion. So our first question that we're going to start off with is, are there any other supplements and or vitamins other than baby aspirin that you recommend women who have heart disease symptoms take pre-pregnancy, during pregnancy, or postpartum?
So the research has shown that baby aspirin, or 81 milligrams of aspirin daily between 12 weeks and 28 weeks, has the most benefit to your pregnancy. It can decrease the risk of some of these high-risk conditions like gestational diabetes, gestational hypertension, preeclampsia, and the outcomes of pregnancy have been better in those patients who have taken 81 milligrams of aspirin. As far as other supplements go, the only other supplement that we really encourage women to take while they're pregnant and even before they get pregnant, if they're even considering getting pregnant, is folic acid.
Right. Folic acid. Yes. If you could just touch on the benefits of folic acid.
So folic acid works to help prevent open neural tube defects or any kind of defects in the formulation of your of the fetal kind of central nervous system spine. Okay, so usually by the time you know you're pregnant, you're already probably 6-7 weeks along, and the fetal organs start to form at 3 weeks, right? So if you are taking folic acid when you find out that you're pregnant and you're already like 7-8 weeks along, the benefit is very decreased if you start taking it at that time. So that's why we tell women, if you're thinking about getting pregnant or you're trying to get pregnant, you should be taking folic acid already to help prevent these neural tube defects and abnormalities of the central nervous system.
Okay, yeah, thank you. Thank you for letting us know. That was very informative. Dr. Paul, do you have anything to add on that? We have about 5 more questions so far. So if not, we can move on to the next question. Okay, next question. Does hypotension impact pregnancy? Now, hypotension is low blood pressure.
So yeah, I do have a lot of patients who will come up to me and say, yesterday I was at work and I almost passed out, and they checked my blood pressure and it was very low. And this is super common in pregnancy for a variety of different reasons. The most obvious are changes in your blood sugar. So when you're pregnant, everything that your body's going through is exaggerated. So if I go through the whole day and only drink 1 glass of water, my urine's going to be pretty dark and I might not feel that great, but I'll probably be able to get through my day. When a pregnant woman does that, her symptoms are exaggerated. She'll have a headache. She may start having abdominal cramping or uterine contractions. And also, being dehydrated in pregnancy can cause your blood pressures to drop very low. And you can feel like you're going to pass out.
Right.
Another thing that can happen is we tell pregnant women to eat small frequent meals that are high in protein to help your blood sugars kind of stay stabilized throughout the day. So kind of eating foods that are super high in carbs will spike your blood sugars really high, and then they'll drop. And when they drop, you will have the sensation of passing out. So you'll get sweaty, cold, clammy, your blood pressure will drop, your heart rate will go up. And usually if they check your blood sugar, it's usually fairly low. And it corrects itself very quickly because pregnant women are usually young, and the body has mechanisms of trying to correct things like this. Right. But this is super common in pregnancy. So I always tell women to stay hydrated, make sure you're eating small frequent meals that are high in protein, to kind of keep your blood sugars under control. And then the other thing, and it's a little bit less, it's less common, but you can have arrhythmias in pregnancy, and I let Dr. Paul talk about this a little bit more, which can cause your blood pressures to change and feel like you're going to pass out.
Yeah, for sure. Definitely during pregnancy, women who already have a history of arrhythmia. And so when we say arrhythmia, we're talking about very fast heart rhythms, usually from the top chambers of the heart. So usually what we say supraventricular arrhythmia. And if you have a history of that even before pregnancy, during pregnancy, they may start to occur even more frequently. And the thought process is that's due perhaps to the hormonal changes, or also like Dr. Beauzile had mentioned earlier in this discussion, that the heart undergoes changes to support the pregnancy. And so one of the changes is you'll see stretch of the atria, so the left and the right atria that are kind of the rhythm centers of the heart. And because of that stretch on that center, it can sometimes make the heart get a little wonky. So you'll start having these very fast heart rhythms. And so when the heart is beating super fast, there's not enough time for the heart to appropriately fill with enough blood. And so then you're going to get less perfusion of blood to the brain, less blood out to the periphery. And so you'll see blood pressure drop, and you'll start to feel symptoms of low blood pressure.
Okay, thank you. Yeah, I didn't really think about the relationship with hypotension and pregnancy. So that was definitely helpful. I'm going to move on to our next question, which is, does hookah affect fertility?
So, yes, hookah's become a lot more popular.
Yeah, it's very popular now.
Yeah. And some say, if you do hookah one time, that's smoking 50 cigarettes at a time.
Right.
And so, like I said, if you're extrapolating kind of the data on smoking cigarettes, it can negatively affect your fertility, right? So it can affect the sperm again, it can affect sperm motility, and it can also affect your cervical mucus. It can affect your tubes and how they, because your fallopian tubes are kind of what picks up your eggs every month,
Right.
and the egg gets fertilized in the fallopian tube. And so the fallopian tube can actually be affected by tobacco and additives in cigarette products.
Yeah.
And so while I don't know about all the additives are in hookah, because we know the effects of cigarettes and tobacco on fertility and pregnancy, you can extrapolate that with hookah as well.
Right. We can kind of just assume that data correlates with hookah.
Right.
And I do think, like, in the future, there will be studies on like how hookah affects it, how marijuana affects fertility, right? But we're just not there yet.
Yeah.
So thank you for addressing that. I'm going to move on to our next question. And it says, hi, my name is Tiffany. Thank you, Tiffany, for your question. NYC-based lab technologist. I'd like to ask Dr. Beauzile about, I don't want to butcher this, but hyperemesis gravidarum.
Hyperemesis gravidarum.
Yes, as this is usually diagnosed in pregnant women. I learned about HG when I shared my cycle symptoms. I've had for as long as I can remember nausea, severe vomiting with my therapist. Healthcare providers have not been able to diagnose and only recommend birth control. Is it possible to have HG if you're not pregnant, or is there a diagnosis for these symptoms in people who aren't pregnant, possibly hormone linked?
So hyperemesis gravidarum is specifically a disease of pregnancy. And one of the reasons why women do have a lot of nausea and vomiting in pregnancy is because of that beta HCG, or it's called the pregnancy hormone. And early on in pregnancy, the beta HCG gets really, really high. And in patients who have hyperemesis gravidarum, their HCG is really high, and that triggers nausea, vomiting, unable to tolerate any kind of food or drink, and then changes in their weight and changes in their electrolytes, which kind of gives them the diagnosis of hyperemesis. So if you're not pregnant, you technically can't have a diagnosis of hyperemesis, right? Because specifically it's because of pregnancy. Yeah. But in patients who have nausea and vomiting, especially when it's chronic nausea and vomiting, I see patients like that all the time. And I see patients like that later on in pregnancy when hyperemesis isn't actually the reason. But having, uncontrolled acid reflux disease can cause nausea and vomiting. If you have like a hiatal hernia or some kind of GI tract abnormality, that can cause nausea and vomiting. Actually, in recent years, I've seen a lot of patients who have marijuana toxicity that causes extreme nausea and vomiting. Nausea and vomiting can also be psychogenic. So it could be a response to stress. It can be a response to anxiety. So if that's really a big problem for you, I really think first you should see like a gastroenterologist or somebody who specializes in the gastrointestinal tract to figure out what is going on, because there's so many different reasons.
Okay, thank you. And just continuing on HG, I have another question here that says, are there any precautionary measures that can be taken to offset the possibility of having another HG pregnancy if you've had one prior?
So for women in early pregnancy, it's normal to have some nausea and vomiting. Again, it's because of those high levels of beta HCG. So there are so many different things that we talk to our patients about. So again, eating small, frequent meals throughout the day, especially in early pregnancy, because when you're pregnant, your GI tract completely slows down, right? So what would take 2 hours to process in my body may take 4 hours to process in yours. So if you're eating a very big meal that's fatty, it's going to stay in your stomach longer, and it's going to make nausea and vomiting worse, right? So when you're pregnant, small, frequent meals that are not very fatty, not very greasy. But even if you do that, it's normal to have a little bit of nausea in pregnancy. So I tell patients salty foods are really helpful. And I know that kind of goes against everything Dr. Paul says, right? But these salty foods will help stave off nausea. Sometimes ginger supplements are really good for nausea. Ginger really
Right. I
helps.
remember seeing some of my patients when I was on the L&D unit having their
Yeah.
little ginger supplements.
Right. And it's the same thing with like ginger ale. You know, I kind of tell patients to stay away from like ginger snaps or ginger ale because yes, there's way more sugar in there than there is ginger, right? But you can go to your grocery store and get ginger, or you can get ginger supplements.
Yeah.
Also, citrus helps. So sometimes eating oranges or lemons, or just even putting a drop of lemon juice on your tongue can stave off some of that nausea. There's those acupressure bracelets that can help, and the motion sickness, like little pads that you can put on your neck when it's really bad. The other thing I always tell my patients is B6 or pyridoxine. It's a vitamin that you can get over the counter. And Unisom, when taken together in early pregnancy, actually really help with nausea and vomiting. So there's a lot of early interventions that you can do before you get to HG. But if you get to HG, definitely you have to talk to your doctor about it, because there's things that we can do to help make those, especially those first 12, 13 weeks of pregnancy, a lot more manageable if you're feeling really sick.
Right. Yes, that's very good to know. So we will be collecting these gems and putting them in a follow-up email, just so everyone knows. So our next question is, let's see, for patients that have white coat syndrome, how often do you suggest that they monitor their blood pressure at home before and after a doctor's visit?
So yeah. Oh, go ahead. Go ahead. Sorry. Go ahead, Dr. Paul.
So I would say half the people who say they have white coat hypertension don't actually have white coat hypertension and actually have hypertension. So, you know, like there are certain people who say like, oh, anytime I come, my blood pressure is high, my blood pressure is high. And I'm like, well, do you ever check it at home? And they're like, no. So it's like, well, how do you even know?
You can't really know.
Yeah. So I would say for this, like, you know, every time I meet a patient, they tell me that, like, I give them the best, like, I believe them, you know, they know their body. But I would say, you know, you need to then do 2 weeks of blood pressure measurements for me and send me a log. And just like Dr. Beauzile mentioned, it's the similar way we say in cardiology to measure it. You need to sit in a quiet place for at least 5 minutes and take a few readings, okay? And then you send the lowest reading, like the third reading that you got. So you do the first reading, you kind of throw that one away. You do a second reading and then a third reading. Sometimes, you know, people don't have time for that. So then actually just send us the second reading. And then you either send us the lowest reading or an average of the last two. And I would say typically the people who say they have white coat hypertension, when they send the log, they do have hypertension. They may not have like a blood pressure of 160 over 90 or 160 over 100, but their blood pressure could be, you know, like 140 over 90 or like 135 over 85. So I would say one is that, like, if you think that you have a diagnosis of white coat hypertension, I would say, you know, pick one time a day. So if you like the morning time, afternoon, whatnot, and measure your blood pressure for 14 days and keep a log and see.
Right. So you get accurate readings. Yeah. No, that's important so that we get accurate readings so we can get the proper treatment, right? I think sometimes with white coat syndrome, people don't want to believe that their blood pressure is elevated. So it is important that we just take that time out to just measure our blood pressure and see how our blood pressure is being affected. So let me move on to the next question, which is also regarding hypertension. So if someone who has hypertension is considering an at-home birth, what things should they take into consideration when making this decision?
So a patient who has hypertension in pregnancy would be considered a high-risk pregnancy. They're at risk for having preeclampsia. And they're also at risk when you have hypertension of having thyroid dysfunction, as well as gestational diabetes. So that patient by themselves, just with that history of hypertension, I would not recommend a home birth.
Okay.
Because typically what happens if you have hypertension, it can progress to preeclampsia towards the end of the pregnancy very quickly. And preeclampsia can progress from mild preeclampsia and very mild symptoms to seizures and stroke very, very quickly.
Life-threatening.
So, exactly. So in a patient with hypertension, I would not recommend a home birth. I would recommend having your child in a hospital, or doing your delivery in a hospital, because during labor in a patient with hypertension, we're going to be checking your blood pressures, we're going to be checking your fluids, we're going to be monitoring baby, and that's going to be continuous throughout your entire labor, however long it is. And you obviously can't get that at home. And so you can't really monitor any changes in the clinical status of the patient when they're at home. Obviously, I would love to be able to tell all my patients to have their births at home in places that they're familiar with, not having the stress of the hospital and people coming in and out. But just for safety, I would not recommend a home birth for someone with hypertension.
No, thank you for shedding light on that, because of course we want everybody to, exercise all the options available to them. But sometimes because of high risk pregnancies, you don't necessarily have that option. So it's important to know that. I just want to transition into our second to last question, which is, can you elaborate on how smoking affects fallopian tubes, like the pathophysiology behind that effect, please? So our audience is very interested in how smoking affects fertility and pregnancy.
Okay. So with your fallopian tubes, they are little tubes that are attached to your uterus, and they have kind of finger projections, kind of looks like this, and they're called the fimbria. And those are attached they're basically at the very end of the tube. So it's one long tube. There's the fingers at one end, and the other end connects to the uterus. So every month you are born with, you're born with a number of eggs that you're going to have. And every month you make follicles or little tiny cysts in the ovaries, and each of those follicles have eggs in them. One of the follicles will become the mature or dominant follicle and rupture and release your egg that has been chosen to be the one that could potentially be fertilized and get you pregnant, and the rest of them die off, right? So when you ovulate, you essentially are rupturing that follicle or rupturing that cyst. The egg kind of just hangs out in the pelvis, and these little fingerling projections pick up the egg and sort of move the egg into the tube, into sort of like the center of the tube close to the uterus. And then the egg waits there for the sperm to be fertilized. So with smoking, the additives that are in cigarettes can affect the motility of those fingerling projections and make it so that they don't function as well to pick up those eggs. It can also affect the tube, right? So it can cause the tube by itself to spasm. So you can have the egg in there, but then the tube could spasm. And let's say that the egg gets fertilized. Now it can't move into the uterus because it's spasm or it's diseased. And then you could end up with an ectopic pregnancy where that fertilized egg starts to grow and grow and grow. And normally it would move into the uterus and implant into the endometrium. But because that tube is diseased, or because the motility of the tube has now been affected by the additives in cigarettes and in tobacco, it's kind of planted there, it stops, and the pregnancy continues to grow in the tube. But obviously, you cannot grow a full-term pregnancy in the fallopian tube. And what will happen is that pregnancy will rupture the tube, and you'll start to bleed into the abdomen, which is a surgical emergency. And then we have to go in surgically and remove that tube, remove that pregnancy, and help you to stop bleeding.
Right. An ectopic pregnancy is definitely very dangerous and life-threatening. So thank you for, providing this information on that. So we're coming up on time, and I definitely want to end on a positive note. And I want us to leave here feeling empowered, especially as Black women. So my last question is going to be, what are some ways to advocate for yourself when you feel you're not receiving the best healthcare? We all know about the statistics when it comes to the healthcare that Black women receive.
So I would say one way to advocate for yourself is to just kind of lay it out there to the doctor you're seeing and being like, I've been watching the news, I've been reading things, and you know, as a Black woman, I know that my risk of having a poor outcome with pregnancy is high. You know, what do you think about that? Like, are you aware of this? You know, and the doctor, and if the doctor's surprised and has never heard this, then that means you need to go find a new doctor. You know what I mean? Like,
Right.
if the
You need
fact
to
that they don't
go.
even know this as a fact,
Yeah.
then you know you need to be looking for another doctor. So it's one to like see like where they are, like mental space in terms of that. Two, um, and just be very clear with them and being like, you know, like I haven't. You say like, you know, I don't feel like you're listening to me. You know, these are
I don't
my
feel
my
like you're listening.
yeah, I don't feel like you're listening to me. You know, this is what I want addressed, and I'm coming to you for your expertise. Like, what do you think? You know,
Mm,
and then also at the end of the day, one of the nice parts about the U.S. healthcare system is that you can always get another opinion, and you can always see somebody else who you jive with and you connect with. And thankfully, you know, there are apps like Health in Her Hue who is making it easier to connect women of color with doctors, other providers of color, not only of color, but doctors and providers who recognize that, you know, that we need to provide culturally competent care. Okay.
Mm-hmm.
So I think, so to me, that's where I would start, is to just say, you know, I don't feel listened to, you know, and it doesn't have to be in a confrontational way. You say how you feel. Um,
right.
and if you don't feel comfortable doing that, you know, I'd also say get a second opinion. And another thing, and a third thing too, is that like when you're looking for a doctor, I mean, I think nowadays it's very easy to just go online and like try to look up reviews or whatnot. But I think the best way is to ask friends and family who you trust
Mm,
their opinion, and they will refer you, because there are some doctors who like love them to death. Like they're just not like internet like media people. So there are some people who have like a fantastic reputation, but you don't know that when you go online, because like they don't like actively court reviews, you know, they're like whoever they work for, like that's not like if they have their own practice or like they
maybe
work
they're
for
not a
other.
doctor.
Exactly. So I would say like that's not a thing. And then another thing too is like, you know, like sometimes some of us will be like, oh, well, I'm not gonna see that doctor because they don't have weekend hours, or they don't have like, you know, like late night hours. And I would say, you know, if you are able to and can take that time off from work, and it's a doctor that you know has a good reputation, I would take that time off to go, because your health is important. And so you don't want to always pick the person who has an office like literally 5 blocks like around the corner,
Yeah.
and they don't have the best reputation. You know what I mean? So it's like it's those sorts of things. So like your health is really like the most, I mean, this year has shown it to all of us. Like our health is really the most important thing that we have, like bar none. And so we have to be very
Exactly.
proactive about it.
Yeah. No, I love that you touched on that, because I've definitely had, situations where I felt unheard or unseen from my OB providers, right? And I was like, am I doing something wrong? And then eventually I was like, no, it's them. It's not me, right? They're not listening to me. And I'm an RN, and I felt like that. So I love that you touch on, asking family and friends, going to a practice that may not be, right down the street, right? It's important. And Dr. Beauzile, do you have anything to add to this?
Yeah, I agree with everything Dr. Paul says. I think that word of mouth is way, way more valuable sometimes than online reviews, because patients who are satisfied with their care and have a good experience aren't always going to go online, right? Because they're happy with their doctor and they're living their lives and they just don't feel like going online. They have other stuff to do. But if you've had a really, really bad experience and you don't feel like you're being heard, the biggest way to be heard is to go online. And so, sometimes you really have to kind of take those reviews with a grain of salt, right? Because a doctor may have like a really, really bad review, but it's just the one, and that patient was really upset. And maybe that doesn't really translate to that patient, to that doctor's care, versus a doctor that has like a lot of really, really good reviews. You should wonder about that too, right? Why does that doctor have so many reviews? Are they like paying for them? Are they asking the patients? So there's just a lot of other things to consider when you're looking at these online reviews. I would also add that usually every doctor you see is being managed somehow or some way by like a practice manager or a hospital or some kind of group administrative person. And so sometimes it's going to be hard and it's intimidating, right? To go up to your physician and say like, I don't think I'm being heard, right? Like, yeah, some of us can do that, but a lot of us can't. That's not really easy to do. You can't sometimes even do that with like your friends, right? So imagine doing that with a stranger. So sometimes maybe just say like, can I talk to the practice manager? These are my feelings. You know what I mean? And then if the practice manager hears you out and they really have like make a solid effort to try to make you feel more comfortable, then that's probably a good place to be versus a practice manager or whatever representative of that physician or group that kind of dismisses you, then maybe that's somewhere that you may not want to be. So talking to your doctor may help, but sometimes you may have to go above and beyond and maybe talk to someone that represents that physician, represents that group.
Exactly. Thank you. That's important for us to be our own advocates. And like Dr. Paul mentioned, also utilizing apps like Health in Her Hue, right? Digital platforms that connect us with culturally competent providers. It's so important for us to just make sure we're utilizing all our resources. So thank you all for providing all of these gems tonight and all of the information. I feel like I learned so much during this discussion. Please feel free to drop any comments in the chat box. And also we'll be following up with an email where we just like wrap up some of the gems that were dropped tonight. I'm so happy that you were able to join us. This was a great discussion and I even feel more empowered, right? So thank you so much again for coming to speak with Health in Her Hue and Black Health Connect. Thank you everyone who showed up. And yes, do you all have any ending remarks?
So I would say, step one is it's just having knowledge about these issues so that you can feel empowered. So you know that you know what to ask and you know what to pay attention to, like when you are in the doctor's office or if you are seeing like a nurse practitioner or a midwife. And I think, any woman who's like thinking about pregnancy, like Dr. Beauzile said, take your folate, know your numbers, know like what your blood pressure is, know what your cholesterol, like have those clues, like the basic stuff that we should be doing that we may not have done last year because of the pandemic. Now maybe the time to be like going back to your primary care doctor to be like, like I haven't had a checkup in like over a year or so. Let me just see where I am, to just make sure that you're on like the right path. So when you do decide to become pregnant, that you're optimized in that way. And another thing, that we didn't necessarily talk about, but I would say if you're thinking about pregnancy, then you also need to be thinking about and deliberating if whether you should get the COVID-19 vaccine. Okay, because we do know that pregnancy places one at risk for severe COVID infection, and so that's another part that's going to need to be in preconception counseling is like should you be vaccinated?
Right. And I feel like that's a whole other discussion that I want to have. I want to expand this and talk about the vaccine and pregnancy, but we will say that for another time. Dr. Beauzile, do you have anything to add before we close out the conversation?
So I won't touch on the COVID vaccine for pregnancy, but I would do it if I was pregnant. And then the other thing I would say is when you're picking a provider, it's just like picking someone who you feel like you would hang out with and talk to, right? So if you don't vibe with that person from day one, you're probably not going to vibe with them probably for the rest of the relationship. And if you don't have a good feeling about that provider, that's going to color everything that happens, every interaction with that provider, whether or not they do a good job or a bad job. If you don't like them, everything they do is going to be wrong. And when you like your doctor, everything they do is right. So kind of consider when you do meet your provider for the first time, how do you feel? Like, what vibe are you getting from them? Do you feel comfortable talking to them? Then that's probably someone you can stick with versus if you get a vibe right away. And a lot of this stuff is subtle and it can't be tangible, but you kind of feel, whether or not you like a person pretty much very
that intuition.
Yeah, exactly. So trust your gut when you're picking your providers, just like you would when you're picking your friends, when you're meeting someone new.
Right. Well, thank you, Dr. Beauzile. Another gem dropped. Thank you. Thank you both. Thank you, everyone, for being a part of this discussion and showing up tonight. I see that we're definitely going to have a part 2 where we discuss the vaccine and pregnancy. So yes, thank you, everyone. We're going to be closing this discussion. Thank you so much, Dr. Beauzile and Dr. Paul. Everyone have a good night.
Thanks.
And stay safe, and hopefully this provided you with some great tips.
All right. Good night.
Bye.
Bye.
Good night.
Good night.